So I've spoken about the different side effects of opioids. And before we go on, we're going to talk about tolerance and withdrawal syndrome. So tolerance occurs when there is an increased need for higher doses of the opioids in order for it to be effective. If chronic use of the opioid is discontinued, symptoms of withdrawal that result from cessation of drug administration usually occur within 24 to 48 hours after the last opioid dose. Withdrawal syndrome is caused by physical dependence. Symptoms include irritability, diaphoresis, restlessness, muscle twitching, tachycardia, and increased blood pressure. The withdrawal symptoms from opioids are unpleasant, but are not severe or life-threatening. In terms of contraindications for opioid analgesics, opioids are contraindicated for patients with head injuries because the opioids cause a decrease in respiration, which can promote carbon dioxide retention, leading to increased intracranial pressure. Opioids given to a patient with respiratory disorder only intensify the respiratory distress. In patients with asthma, opiates decrease respiratory drive while simultaneously increasing airway resistance. We talked about opioids can cause hypotension, so in a patient with shock or very low blood pressure, if an opioid is necessary, the dosage may need to be addressed accordingly, or the hypotensive state may worsen. You may have heard of a PCA pump. PCA stands for patient-controlled analgesia. And just like it states, it's the patient controlling their own doses of pain medication. So basically, it's hooked up to the pump, and the patient usually will receive a loading dose the first time it gets set up so that the patient can get some pain relief. And then the nurse will set the pump according to whatever the doctor orders. So there'll be a predetermined amount of medication that can be administered to the patient. And there's also time limits onto how often the patient can receive the medication. And the medication is administered when the patient hits a button. So they're feeling pain, they can hit a button, and it triggers the PCA pump to administer a dose of medication. There's a lockout mechanism on the pump that prevents the patient from continuously pushing the button and causing a drug overdose. So there's no risk for overdose with a PCA pump. There are time intervals that are set when the device will allow the patient to administer pain medication. So if they hit the button too early, they're feeling pain and they hit it, and the correct amount of time hasn't passed, the pump won't administer the medication. The big patient teaching takeaway in regards to PCA is that it is imperative that the patient, not the family or the nurse, control the PCA device. Okay, so only the patient should hit the button to administer medication. Another route that opioids are administered is through the transdermal route. Transdermal opioids analgesics provide continuous around-the-clock pain control that is helpful to patients who suffer from chronic pain. So continuous pain control for chronic pain. Fentanyl is a popular transdermal pain patch that patients will use. Fentanyl, if you remember, is more potent than morphine. And the patch can be available in different strengths depending on the patient's needs. All right, analgesics in special populations. In regards to children, pain management can be difficult because sometimes it's more difficult to assess the pain. The child might not be able to verbalize the pain. One of the scales used to help a child quantify their pain is the Ouch scale, which uses faces from a smiley face meaning no pain to a sad face with tears meaning the worst pain. We also want to involve the parents in the pain assessment because they may be able to provide some information about where the pain is and to what degree the child has been experiencing pain. Children, like adults, should be given pain medication before pain becomes too severe, and oral liquid medication for pain relief is appropriate and generally more acceptable to a child. In older adults, side effects from use of opioids are more pronounced. Therefore, the nurse must closely monitor for adverse reactions in older adults who take opioid analgesics. As a person ages, liver and renal functions decrease, which cause the rate of metabolism and excretion to decrease, and that can result in drug accumulation and or toxicity. Older adults tend to have different beliefs and fears than younger generations regarding opioids. They may believe that pain is inevitable due to aging, or they may fear addiction. The nurse must perform pain assessment with a supportive approach in an unhurried manner and should give the patient accurate drug information. Pain assessment may be more difficult if the older adult has decreased cognition or problems hearing. The nurse may need to rely on a more thorough physical assessment to discover the presence of pain because self-reporting may not be reliable. In the presence of decreased renal or hepatic function, drugs that tend to be more toxic in older adults, including meperidine, need to be monitored closely. Analgesics are usually metabolized in the liver and excreted in the urine. Usual doses of analgesics in older adults may result in excessive sedation or prolonged duration of action. Age is one of several factors that influence medication use and dosage. Comorbidities of the older adult must also be considered. Any cognitively impaired individual may be unable to report pain adequately. The nurse should use a measurement scale that is appropriate for the patient. Some physical signs of pains include moans, grimacing, clenched teeth, noisy respirations, and restlessness. Cancer pain is managed according to 3 levels of analgesia based on the WHO ladder. There's a step 1 for mild pain, step 2 for moderate pain, and step 3 for severe pain. And basically with step 1, mild pain, the cancer patient would start out taking non-opioids with or without adjuvant medications. Step 2, the patient would have non-opioids or mild opioids with or without adjuvant medication. And step 3, for severe pain, stronger opioids at higher dose levels with or without adjuvant medication can be expected. So it would not be uncommon for a cancer patient to be on some pretty strong opioids and at a high dose in order to continue making sure that that patient is comfortable. Often patients with a history of substance abuse disorder require pain medication. A thorough pain assessment is necessary. The nurse needs to know that opioids are effective and safe in this population, even though larger doses and greater frequency may be required. Studies have shown that withholding opioids in this population has not increased recovery from addiction. However, opioid agonists/antagonists should be avoided in chemically dependent patients because these drugs may precipitate withdrawal syndrome. Medications used in adjuvant therapies are used alongside with a non-opioid or an opioid. They may include anti-seizure medications such as gabapentin, which act on peripheral nerves in the CNS by inhibiting spontaneous neuronal firing. They are used for neuropathic pain and for prevention of migraine headaches. Tricyclic antidepressants, such as amitriptyline, prevent the reuptake of serotonin and norepinephrine in the cells. Lower doses of TCAs or tricyclic antidepressants than those usually prescribed for depression are effective in treating peripheral neuropathy. Corticosteroids serve as an effective analgesic by reducing nociceptive stimuli. And then antidysrhythmics block sodium channels to reduce pain. Local anesthetics, if you see the word local, it means at the site at the specific site. In this instance, local anesthetics would be pain relief at the site, such as a lidocaine patch, can provide effective analgesia by interrupting the transmission of pain signals to the brain. The dosage of the adjuvant medication when used in conjunction with an NSAID or an opioid may be kept lower than normal to reduce adverse effects. Opioid agonists/antagonists are medications in which an opioid antagonist is added to an opioid agonist, and they may be used to decrease opioid abuse. They are not given for cancer pain because of the risk for potential CNS toxicity from the high doses required. Safety during early pregnancy has not been established. but they are considered safe to use during labor. Your prototype opioid agonist antagonist is nalbuphine. Nalbuphine is a opioid agonist antagonist that is effective in alleviating moderate to severe pain. Prior to administering the drug, we'd want to get a baseline set of vitals for a future comparison. The goal is that the patient will experience pain relief. After administering the medication, we want to monitor vital signs and monitor patient's rating of pain. Monitor bowel movements and urine output. Check bowel sounds and the date of last bowel movements to identify constipation and determine urine output. We're worried about decreased peristalsis that can cause constipation. And if that occurs, a mild laxative may be necessary. And we want to monitor urine output. Report if a urine output is less than 30 milliliters per hour or less than 600 milliliters per day. We want to advise the patient not to use alcohol or other CNS depressants while taking nalbuphine. Respiratory depression can occur. We want to determine the stability of vital signs, so we want to note any changes in respirations, pulse rate, or blood pressure, and report any abnormal findings while the patient is taking the medication. Next, I'm going to talk about opioid antagonists, and if you remember, an antagonist is a blocker. So opioid antagonists are considered the antidotes for opioid analgesics. The opioid antagonists have a higher affinity to the opiate receptor than the opioid being taken. An opioid antagonist blocks the receptor and displaces any opioid that would normally be at the receptor, which inhibits the opioid action. Naloxone is your prototype opioid antagonist. It can be given by IM or IV route. They can reverse the respiratory and CNS depression that is caused by opioids. When receiving an opioid antagonist such as naloxone, the patient should be monitored continuously. The opioid action may exceed that of the opioid antagonist, and further analgesia may be needed. For example, fentanyl and a combination of drugs given during surgery may lead to excessive respiratory depression. Naloxone may be given as the opioid antidote. The patient's respiratory and CNS status should be monitored closely for indications of analgesic reversal, such as tachycardia, nausea, vomiting, and sweating, and the possible need for further analgesia. The patient receiving naloxone should also be observed for bleeding because the drug may cause elevated partial thromboplastin time. Doses of naloxone often need to be repeated because it has a short half-life that is shorter than that of the opioids, and the opioid effect may reoccur. Naloxone may cause flushing, agitation, hypotension or hypertension, tachycardia, hyperhidrosis, nausea, vomiting, and dyspnea. Again, it's important to monitor vital signs and signs of bleeding after administering an opioid antagonist such as naloxone.